all the faculty, and a sincere thanks to Srinath sir and the organizing team, Dr. Karthik and Dr. Sriram for having me here. So the topic which I've been asked to speak on is on sialocele and parotid fistula. I think in an oncology setting this would not be of paramount importance because most of the times it will get overlooked. So, but I'll just try to put in, what are the treatment modalities, how we can best avoid it, and just run you through my presentation. So, we'll just look at it from a few aspects like what's the definition, how do you diagnose it, and management. Very simple, basic tenets here. So, the first thing would be for the trainees at least, try to identify where the parotid duct comes. So, the classic teaching is you've got a line which is going to be drawn from the tragus to the philtrum. So that's classically the axis along which you have got the stencils duct lies. Another way in which you could identify it would be look at it when in close relation to the facial nerve. So between the two divisions of the upper and the lower buccal. And that's the area where you have the parotid duct is there, and it courses over the masseter, pierces into the buccinator, and then opens into the oral cavity opposite the second molar. Now, most of the evidences which come from the management of sialocele and parotid fistula are primarily extrapolated from traumatic injuries to this. So, going to the old classification of Van Sickle's classification, wherein they put it as basically three forms of injury. You can have it happening right at the parenchyma of the gland, you can have it happening superficial to the masseter, or you can have it distal to the anterior border of the masseter. I think when we look at it from the oncology point of view, it will be primarily coming somewhere in the area around the B zone, where you will be having it somewhere superficial to the masseter. So, having said that, I think the primary area where we as surgeons would be looking at it, where we identify the parotid duct. So, a good way to look at this would be when you incise the parotidomasseteric fascia, you're clearly able to see the parotid duct which is going over the masseter, getting into the buccinator before piercing into the oral cavity. That would be the point where ideally you should identify it, ligate it and secure it, especially when you are dealing with a malignancy of the oral cavity where it requires it to be transected. Subsequently, most of the times where you would discover that a parotid sialocele is in, you have the imaging and you see this clearly well circumscribed uniformly enhancing lesion that comes up in your imaging, which shows a sialocele. Now, how do you go about managing it? Now, most of the times it's a very conservative form of management because it's just a disruption of the parenchyma of the gland or the salivary duct with saliva extravasating into the subcutaneous tissue. If you look at it from the definition point of view, salivary fistula develops much more earlier than a sialocele. A sialocele would be about 10 to 14 days. And you would have an antecedent history of having done some sort of surgical procedure, at least a parotidectomy. Literature has tried to look at, especially in the development with different forms of conservative parotidectomies, like which part of the parotid is the one which is most susceptible. So they say that it's tail parotid, and when you're going into the middle zone, that you could have a sialocele. Oral cancer, especially buccal mucosal cancers, would develop a sialocele. A parotid fistula, on the contrast, would be when you have a tract which is communicating with the skin and between the gland with an external drainage of saliva. So, by definition strictly, it develops much more earlier than a sialocele. So, the risk factors are again, you look at the extent of parotidectomy, inferior and middle, having it to be a little more higher risk, neoplasms and surgery. Of course, if you've got a parotid duct injury, infection, stenosis, and you've got a subsequent expansion of the parenchyma and the gland, or of course blunt or penetrating trauma. The presentation is quite simple. You have a history of having some form of injury. There would be a soft and a mobile swelling. Rarely do you need to send it for a salivary amylase, but textbooks would say that you've got a concentration of more than 10,000 of per international unit per liter would be confirmatory. Imaging, I think an ultrasound would be the basic one which would show it up. If you are concerned in terms of a salivary fistula, probably a silography and an MR would give you information about where exactly the tract is draining from. Principles of management are very simple, so it's mostly conservative. Observation, antibiotics just to make sure that you don't have any superadded infection. The classic form has been pressure dressings, which would be the most conservative form. Repeated aspiration, Medications, basically anti-sialogogues. Of course, you've got a whole spectrum: propanthylene bromide, you've got glycopyrrolate is given. Keep suction drains for a longer period. Botox has gotten a lot of literature about there, where they say that under image guidance, if you give about 45 to 200 units of Botox about 1 to 2 weeks, basically in the subdermal plane, it can cause most of these to resolve. Of course, most of the cancer patients would go for radiation, so that's why it is considered to be a very self-limiting one. Very rarely do you go in back and repair it and stent it, and of course, the other one would be to do a tympanic neurectomy. It's a simple thing, so I think I'm open to questions. And the other thing would be extending a warm welcome to all of you all for FHNO 2025. I think the whole group is here who are part of the core group. It's on the 7th and 9th, so I'm sure we'd really love to have you here.
I can tell you, I just narrate an interesting case. This happened recently. I had done a white marginal resection. We put in a ANT flap. A patient healed very well, was not a candidate for adjuvant RT. Depth of invasion was not enough, NZ on it. Came back maybe 10 days later. He said that when I bent down, one of my nostril has clear fluid. And I thought, maybe I might have taken one of the osteotomies too high. I asked him to collect it. He sent it for beta to transfer and came out negative. So I thought maybe it is just some kind of allergic rhinorrhea. I gave him medication, then didn't resolve. Then he showed me videos. There was tickling down. I asked him to come, and I said, "Now show it to me." He said, "Now it's not coming." So when does it come? After I have a meal, sir. So what had probably happened is that the ligation had slipped, gone into the lower cuttage of the maxilla, and from the ostium it was coming into the nose. It was not a candidate for adjuvant RT, so it took a long time to heal. Sialocele developed, came out on the external surface of the skin. We gave him, so another learning lesson was that we gave him glycopyrrolate, but he was taking it intravenously. What happens if you give glycopyrrolate intravenously? It acts quickly. It causes tachycardia, doesn't last longer. So if you're giving glycopyrrolate, best to give it IM or in capsule form. So that was something, a very unusual presentation of a sialocele for me. Just worth mentioning.
Of course, this is very rare. Fortunately, it is very rare. It's a salivary leak, and this is very, very rare. See, in cases of parotid, in my entire experience, I might have come across 3 to 4 cases. But most of the cases, of course, I did a conservative line of treatment. It has settled. 1 or 2 patients, it has extended up to 1.5, 3 months. But we, being a surgeon, we feel it is a bit headache. If a patient gets, he will go home and then comes back with a salivary leak. I felt it. What is the reason why some of the patient, very few patients, they get salivary leak? Is it because we are leaving lot of chunk of parotid in spite of doing a parotidectomy, with a conservative parotidectomy, or suppose in a cases where we have done a complete resection of parotid? I have not come across a single case. But in a superficial conservative parotidectomy, a chunk of parotid that we are leaving, probably that in spite of ligation of the parotid duct, I am always having that fear that this patient may come back with a fistula. Of course, in oral cases, as he said, when you are raising when you are resecting, blindly we separate the parotid, and sometimes it disturbs the salivary secretion, and postoperatively, even after good healing, they get the fistula, salivary leak. But as you said, if the patient goes for radiotherapy, it will settle. But as far as parotid, I just want to know whether the leaving chunk of parotid is the cause for salivary leak, in spite of ligation.
I think it would do primarily with the amount of residual parotid tissue that we leave behind. So especially when you do something like an adequate parotidectomy and you're leaving behind the acinine also in the superficial lobe, that would be the one which tends to subsequently form either a sialocele or a salivary fistula. Of course, in the malignancy setting, definitely there would be a formal identification of the duct, ligating it, and then subsequently if patient gets into adjuvant radiation, it gets taken care of. It hardly gets noticed. So you had a point of view.
I think, sir, the problem is the way we are taught to do parotidectomy. Everybody tells us that it's a superficial and a deep. And then they say that the duct is a deep structure and you should not resect it in a superficial parotidectomy. So the mindset is, when we are going along the duct, we are trying to save the duct. And if you understand the embryology of the parotid, it's going from the oral side to the lateral. So the SNR system is well developed medially rather than laterally. So you have larger canaliculi medially. So if I'm going to leave a larger chunk of tissue and not ligate the duct, I will leave behind a functioning gland, and 80% of the superficial lobe, which is above the masseter, is functional. So if I'm going to leave that part of the functional gland and an intact duct, I will of course cause secretion, and then usually the duct is non-functional because you would have you would have damaged it. So there will be a collection. So like we do in a routine parotid for malignancy, you're going to take the entire duct and everything, and that's why we no longer see it. But the ones that you do an adequate parotidectomy or you open the capsule and fail to suture it, that's where we will see a sialocele.
So just add on to that, if the patient has continuous fistula and a leak, and unfortunately let us say the patient, the final histopathology is benign, but doesn't require a radiation. Now I have read few papers on the concept of completion parotidectomy, because it is so bad that the multiple fistulas have opened up. Any sights on that? Doing a completion of total conservative parotidectomy in order to feel it's an overkill to.
So I also reference literature with the same case, because this guy was.
I read
so
this
there are two
literature. I was
schools of thought.
surprised with the total conservative
Yes.
parotidectomy in order to avoid the.
Yeah. So explore the wound, find the duct, cannulate it and bring it into the oral cavity in relation to the flap. That was one. The other was to do a total parotidectomy. But both are expeditious exercises. It's not easy.
Yeah,
very
again,
difficult for the patient to get
for
convinced.
facial nerve injuries again.
But I don't think it should be done any longer, because it's going to put a patient at risk for a nerve injury. And you have botulinum toxin, which will work wonders. So if you have a case which requires it, use a botulinum toxin today. I don't think surgery may be the answer.
You said that you would like to leave the suction drain for a little longer time in case of parotid. Is it usually you do regularly like that, or
It's basically to make sure that the skin flaps adhere obliquate of the thin space if you have a concern of fistula developing. So it's just basically to have that negative suction there and prevent it from accumulating in the cervical site.
yeah? Sometimes I don't know. Is it? Sometimes I feel that it's like a thoracic duct when you keep.
Pulls in more.
Yeah, that's what I was wondering. What is your opinion on that?
So for routine parotidectomy, if the volume of the mass is less than 30 cc, we stop putting drains, because that allows actually some amount of serous collection to form a gel, and it actually causes a better barrier and prevents frays. We have done for the last few years, we have stopped putting drains if the volume is small, and we have to analyze those patients whether they have frays or not. But this is conceptual. The sialocele formation may not be prevented if we are not leaving behind adequate tissue. So I guess if you have done more than 90% of the gland is removed, a little bit at the zygoma, a little bit at the retromandibular area, that's usually where people will leave behind. And that's not adequate to form a sialocele.
Did you say you sutured the gland? Sutured the gland, you said.
Cut it.
If you do an adequate parotidectomy, people open the capsule, remove the tumor, and close the capsule.
Okay.
That's where the suturing comes.